Good morning, everyone. The scope of this session, entitled Laboratory Identification of Protozoa, is to show you how to identify stages from select protozoa in the relevant clinical specimen of an infected patient.
Let's start by the learning outcomes that we will acquire from going through this lecture. First of all, students will be able to develop the ability to identify select intestinal, blood and tissue protozoans based on their morphological characteristics and the corresponding clinical specimen. They will be also learn about the diagnostic methods that are used in order to detect and identify these parasitic infections in humans. Going very briefly over the life cycles, the students will refresh their memories on the life cycles of these select protozoa and their various stages, motile and non-motile ones, which helps them get an idea about the pathogenesis, the sites of infection, and that will of course reinforce what was covered in the lectures. And finally, students will acquire the skills that will prepare them for our interactive session in order to identify, diagnose, collect specimen, and manage the parasitic infections after going through multiple medical cases that we will see together in the interactive session. And you will be able, of course, to identify that parasitic infection based on life cycle, on symptoms, on clinical specimen that is diagnosed or identified, and so on.
As a very quick reminder, and as discussed in previous sessions, we divided the protozoa into intestinal and urogenital protozoa, as well as into blood and tissue protozoa. And if you recall, we divided intestinal and urogenital protozoa according to their way of locomotion into amoebas, which move by pseudopods, and we discussed Entamoeba histolytica among other non-pathogenic species. We then talked about flagellates, which move by means of flagella, and we talked about intestinal and urogenital flagellates. These include Giardia lumblia and Trichomonas vaginalis. We also covered the only single ciliate that might infect humans, which is Balantidium coli, and which moves by beating the cilia. We then moved on into intestinal sporozoa, and at this level we mentioned that these do not move. However, they established elaborate mechanisms of infecting host cells. And we discussed in the lecture Cryptosporidium parvum, Isospora belli, and Cyclospora cayetanensis. We then talked about blood and tissue protozoa, and we divided these into flagellates, which move by the mean of flagella, and these included Leishmania and Trypanosoma species. We talked about sporozoa, and mostly we discussed Toxoplasma gondii in my session, and I'm sure Dr. Awar covered Plasmodia species. Knowing that other sporozoa, other blood and tissue sporozoa may include Babesia microti and Sarcocystis lindemani. Let us start by recapitulating a little bit some of the properties of intestinal and urogenital protozoa. Remember that the mode of transmission of intestinal protozoa is usually oral fecal route or through ingestion of contaminated food or water. They might have some animal reservoirs or water reservoirs, and oral anal route of transmission can be one way of transmission among others, and that's true for Cryptosporidium parvum and Isospora belli. As for the urogenital protozoan parasite Trichomonas, remember that the mode of transmission was mostly sexual transmission. For diagnosis of these urogenital and intestinal protozoa, we might have to use microscopic identification. There are also serology testing methods. Sometimes there are entero or string tests, and these are mostly for Giardia lumblia. And of course, the most sensitive diagnostic tool for all of them remains the molecular tool, which includes PCR among others. The first intestinal protozoan parasite we covered was Entamoeba histolytica, and if you remember, we get infected with this parasite upon oral ingestion of mature cysts in contaminated food or water. Excistation happens in the intestine, and we will have basically replicating stages, which are the trophozoites that will multiply by binary fission, will destroy the intestinal mucosa, and this is why it is called histolytica. And if not treated and in heavy infections, we mentioned that Entamoeba histolytica may leave the intestine to reach extraintestinal sites, which include the liver or the lungs at later stages. We mentioned also that the transmission of the parasites happens upon liberation within the stool of cysts, as well as in fresh stools we might see trophozoites containing red blood cells. As I mentioned on the previous slide, the two life cycle stages of Entamoeba histolytica are the trophozoites and the cyst. Let us start with the property of the trophozoites, knowing that trophozoites are the replicative stages of the parasite that are responsible for the symptoms of the disease. So first of all, you can notice that these trophozoites do not have a regular shape. The irregular shape that we see is really due to the emission of pseudopods, which are the false feet the parasite use to creep over the intestinal mucosa. Another characteristic is that their nucleus contains a very well-defined central karyosome, which is a condensed chromatin that locates really at the center of the nucleus. As for the cytoplasm is usually finely granular and can present some vacuolation at certain instances. And more importantly, when you look at trophozoites of Entamoeba histolytica, you might see several red blood cells inside of the trophozoite. So on this trophozoite, for example, you can see 6 RBCs that were ingested, as well as the nucleus that contains the central karyosome. Remember that diarrhea that is caused by Entamoeba histolytica is bloody, and this is called dysentery, and this is mostly due to the lysis of the intestinal mucosa by the trophozoites of Entamoeba histolytica, leading to this bloody diarrhea. Of note, these trophozoites of Entamoeba histolytica feed both on RBCs and on bacteria of our intestine. Although I mentioned on my previous slide that trophozoites can be detected in fresh isolated stool of infected patients with Entamoeba histolytica, I want to emphasize that the transmission and more sure way of transmission of Entamoeba histolytica remains the cyst. So basically, when we diagnose a patient, we can see cysts in the stool, and these are the cysts that can infect new people in contaminated food or water. I will be discussing on this slide two features of cysts, because we can see two types of cysts in Entamoeba histolytica, one that is immature and one that is mature. The difference between both is that the immature cyst is less circular than the mature one. In addition, within the immature cyst, you usually see one nucleus with a central karyosome, while in the mature cyst of Entamoeba histolytica, we might see 1 to 4 nuclei that usually have chromatin that is around the nuclear membrane and that is usually evenly dispersed and bead-like. You have to also remember that these 1 to 4 nuclei of mature cysts cannot be seen in unstained preparation. We should go for staining methods in order to detect those nuclei. The second intestinal protozoan parasite we covered was the flagellate Giardia lumblia. If you recall, we mentioned that the two stages that are present in the life cycle of Giardia lumblia are the trophozoites and the cysts, and a human infection starts upon ingestion of cysts of Giardia in contaminated food or water. This excitation happens and leads to the formation of trophozoites in the small intestine. These trophozoites replicate by binary fission and are responsible for the foul-smelling and fatty diarrhea without blood, without pus. And within the feces, if freshly isolated, we may see the trophozoites and the cysts, and of course what carries on and is more resistant in the outside environment. Let us start characterizing the properties of the trophozoite stage, which is responsible for the symptoms of the foul-smelling diarrhea. First of all, these trophozoites of Giardia lamblia are pyriform and have a bilateral symmetry whereby an axostyle divides basically the parasite or the trophozoite stage into two equal parts. The trophozoite has also two prominent nuclei, each of which has a central karyosome. In addition, you can see a sucker that surrounds the two nuclei and that enables the trophozoite to bind on the small intestine. And this gives the feature of eyeglasses that surround the two eyes of the trophozoite, which correspond to the two nuclei. In addition, I have to mention that there is also a median body that you can see at the posterior edge of the parasite. And what is very important is that you can see there are different ways to stain these trophozoites, and I'm showing you several pictures of trophozoites. Here, for example, you can see the basal body, which is a disc or an attachment structure that allows the parasite to bind to the intestine. Here you can see the two prominent nuclei, the axostyle that divides the parasite into two parts symmetrically. And this is what we see usually in the stains of preparations. As you can see, it's a pyriform smiley face having two nuclei, an axostyle, the mouth, which is the medium body, and more importantly, it has the 8 flagella. These 8 flagella are divided into. As for Giardia lamblia cysts, which are the form of transmission of the parasite and which we ingest in contaminated food or water, these cysts are usually ovoid. It is of note, and it's very important to know, that the mature cysts possess 4 nuclei, whereas the immature ones have 2 nuclei. And what is different in the cyst stage is that the karyosomes in the cyst stage are eccentrically located, so they're not like the trophozoite ones, where each karyosome is at the center of its nucleus. So it is very important to remember that within the feces of patients who experience symptoms from Giardia lamblia, we can find either mature cysts or immature cysts, knowing that mature cysts possess 4 nuclei, immature cysts have 2 nuclei, and within these cysts the karyosomes are. The second flagellate I want to talk about is Trichomonas vaginalis. This one is a urogenital parasite. It is not an intestinal parasite. It is very important to remember that for this parasite, which is urogenital, the mode of transmission is sexual, and the life cycle includes only one stage, which is the trophozoite stage, that replicates by binary fission and displays the symptoms mostly in women. Men usually are asymptomatic carriers. It is very important to note that if we doubt this parasite, we should examine fresh preparations, because we have only the trophozoites that cannot be maintained for a long while under normal oxygen pressure. So we should go fast to examine whether the trophozoite stages are there in, for example, vaginal discharge of. As for the properties of the trophozoites in Trichomonas vaginalis, I want you to know that these trophozoites are also pyriform like those of Giardia lamblia. However, the number of flagella is different. While in Giardia lamblia trophozoites we can see 8 flagella, in Trichomonas vaginalis we have only 4 at the anterior part, and we have a 5th smaller one that is protruding from the axostyle at the posterior side. So when we talk about trophozoite of Trichomonas vaginalis, we can by preparations see the nucleus, which is one nucleus, the axostyle, we can see the four anterior located flagella, and we can see a short one, which is a fifth that is located at the posterior side. Let us discuss now the only ciliate that can be infecting humans, and I want to remind you that ciliates move by beating their cilia. There are thousands of species all over, but the only ciliate that can be infecting humans causing diarrhea is Balantidium coli. So as typical intestinal protozoan, the way of infection is by ingesting cysts in contaminated food or water, excitation within the digestive tract, multiplication of the trophozoite stages by binary fission. Within the stool, we will have the two forms, the cyst, which is the more resistant, and the main transmission form of the parasite. And we can see in freshly isolated stool the trophozoites that are very characterized by the cilia that surround. So if we go over the properties of the trophozoites, I want to explain first on the schematic representation. Basically, the trophozoite of Balantidium coli is big in size. It is surrounded by cilia that beat all over the surface. The trophozoite contains two contractile vacuoles that regulate the osmotic pressure. These have an oral groove to allow ingestion of food. Evacuation of waste happens by fusion of vacuoles to a certain area in the trophozoite that is called the anal pore or cytoproct, knowing that the oral groove is called cytostome. We can see in these parasites two nuclei, a macronucleus that has a bean-shaped dimension and that is involved in all the metabolic regulation of the parasite, and the small micronucleus, which is in red here. This micronucleus is located in the constriction of the bean-shaped macronucleus, and this micronucleus is responsible for reproductive activities. So when you isolate a trophozoite of Balantidium coli in the freshly isolated stool from an infected patient, you can see the cilia that characterize the external surface of this parasite. As for Balantidium coli cysts, the cysts are usually also big in size. What characterizes them is their spherical to oval shape, and they have a large macronucleus that we can see very well even in unstained preparation. We cannot see the micronucleus unless we do a very high magnification. However, the characteristic of the cysts of Balantidium coli is the size. The cilia might be seen at the inner side this time because they're retracted to the internal surface, but more prominently we can see the macronucleus even in unstained preparation. And remember that for Balantidium coli, the diarrhea resembles that of Entamoeba histolytica, so we can see blood and pus within the stool. I will start now talking about intestinal sporozoa and their characteristics, reminding you that these intestinal sporozoa do not have motility organelles. They do not have flagella, neither pseudopods nor cilia. However, they've got an elaborate mechanism to infect cells, and thus all of them are obligate intracellular parasites. If you remember, in my coccidia lecture, I covered Cryptosporidium parvum, Cyclospora, and Isospora species, and I mentioned that the three of them have a complex life cycle with two parts, one of them that is asexual and another one that is sexual, that leads to the formation of oocysts that are excreted in the feces. So we ingest these oocysts in contaminated food or water. We will have a sexual and asexual cycle within the digestive system. The asexual cycle will lead to stages that are responsible for the symptoms of the disease, whereas the sexual stage will lead to the formation of the transmission form of the disease, which is the oocyst. And remember that under normal immune system, so in immunocompetent patients, all sporozoan intestinal infections are self-limited, so our immune system gets rid of them, but these infections become problematic, even life-threatening in immunocompromised patients. Let us now talk about Cryptosporidium parvum and the characteristics of select stages. So what are the stages that are interesting for you as medical doctors? It is the oocyst that is usually produced within the feces of infected patients. Remember that in immunocompromised patients, you may see a lot of those in the feces if the infection is heavy. What is very important to me is to know that these oocysts are round, are small in size, they are directly mature, so they are directly infective. We do not have a sporocyst inside of these. What we have is four sporozoids that are naked without a sporocyst. So in the oocyst of Cryptosporidium parvum, we directly see four sporozoids that are naked without a sporocyst, which disintegrates under the pH of the digestive tract upon formation. And we can stain these oocysts by acid fast stain methods, and we can count, like here for example, this one is very nice, 1, 2, 3 and 4. So there are 4 sporozoids, and these oocysts can be directly infected. Regarding Isospora belli, which is the second intestinal sporozoan parasite that is also more infective and more symptomatic in immunocompromised patients, the difference with the Cryptosporidium parvum is that the oocysts that are shed in feces of immunocompromised patients are usually not directly infective, which means that they are immature oocysts that are usually oblong to ellipsoidal, and as you can see here, upon excretion you can see a sporoblast that did not yet evolve to become sporocyst containing sporozoids. So that unsporulated immature oocyst will require a certain period of time in the outside environment to become infective, and whenever it becomes infective, it will contain 2 sporocysts, because the sporoblast will divide into 2. These will become 2 sporocysts, and each will contain. This is the mature Isospora belli oocyst. So as I just mentioned on my previous slide, the sporoblast will divide into 2. These 2 are called sporocysts, and each one will contain 4 sporozoids, which means that few days after excretion of immature oocysts, we will get a mature oocyst in the outside environment having 2 sporocysts, each of which contains 4 sporozoids. So the total number of sporozoids in a mature oocyst of Isospora belli becomes. To wrap up on the properties of oocyst of the 3 select sporozoan intestinal parasites, remember that upon excretion, the sporulated oocysts of Cryptosporidium parvum are directly infective. These are small in size, and they contain 4 sporozoids with no sporocyst. For Cyclospora and Isospora, the oocysts are shed in feces of patients as unsporulated oocysts, which means that they will require in the outside environment a small period to become sporulated. Unsporulated oocysts of Cyclospora are smaller in size than those of Isospora, and upon sporulation, the ones of Cyclospora will contain 2 sporocysts each with 2 sporozoids, whereas those of Isospora will become mature and will contain 2 sporocysts, each of which contains 4 sporozoids. So the total number of infective stages in Cryptosporidium parvum is 4 sporozoids, in Cyclospora 4 sporozoids as well, while in Isospora. Now, in this part of the lecture, I will be emphasizing more on the characteristics of select blood and tissue protozoa stages. To remind you, the blood and tissue protozoa are divided into both flagellates and sporozoa. Among the flagellates, I'm sure Dr. Awar covered to you all Leishmania species. Most importantly, Leishmania donovani responsible for visceral leishmaniasis, Leishmania brasiliensis responsible for mucocutaneous leishmaniasis, and Leishmania tropica responsible for cutaneous leishmaniasis. As for trypanosoma, I am sure at this level you know also that trypanosoma can be divided into African trypanosomyces and American trypanosomyces, knowing that there are two species responsible for the African trypanosomyces, which is a sleeping disease, and these are Trypanosoma brucei gambiense and Trypanosoma brucei rhodesiense, whereas the Chagas disease or American trypanosomyces is caused by Trypanosoma cruzi. Among sporozoa, I covered in my coccidia lecture Toxoplasma, and I am sure that Dr. Awar covered to you different Plasmodia species, and I will emphasize on 4 species responsible for different spectra of malaria. These are Plasmodium falciparum, which is responsible for the most deadly affliction over all human parasitic infections, Plasmodium malariae, Plasmodium ovale, and Plasmodium vivax. To note that these are not the only species that can infect the humans. There are others, such as, for example, Plasmodium knowlesi. A quick reminder on Plasmodia species life cycle. As I previously mentioned, there are several species that can infect the humans and cause malaria, and I would like to remind you that all these Plasmodia species share the same life cycle, and this cycle includes mostly 3 parts. A part that happens in the mosquito, which is Anopheles, and this is the sexual part of the life cycle. And upon a blood meal, this mosquito will inject to us in our blood stages, which are called sporozoites, that will trigger the liver in order to start a part that we call exoerythrocytic cycle, in which hepatocytes will experience multiplication of merozoites, then formation of a schizont, then rupture of these schizonts to liberate more merozoites that this time will leave within the blood to target red blood cells. And within the red blood cells, we will have an erythrocytic cycle in which RBCs that can be different according to malaria species between young or mature or any type according to species can have the exoerythrocytic cycle in which we will have a ring stage first. The ring stage will mature into a trophozoite stage, then into a schizont stage that will contain different numbers of merozoites according to species. And ruptures of these schizonts will further liberate more merozoites to infect new RBCs, and another erythrocytic cycle begins. Some of the trophozoite stages will transform into gametocytes in our blood, and the Anopheles, upon taking a new blood meal, will ingest these gametocytes, in which we will have differences, and I will come later to these differences, but I want to dwell your attention that for Plasmodium falciparum, gametocytes are cricentric, whereas for the 3 others, Vivax, Ovale, and Malariae, they have oval shape, and we cannot distinguish them upon seeing them under a microscope in a blood smear. So for the 3 species, Vivax, Ovale, and Malariae, we have to look for other characteristics in order to identify them in a blood smear. Now, when the mosquito takes these gametocytes, in the intestine we will have formation of the microgametocyte and the macrogametocyte, which will fuse to form an ookinete that will evolve into an oocyst, but this time containing thousands of sporozoites, not for the others, whereby basically the number of sporozoites ranged between 4 and 8 maximum. In the oocyte of Plasmodia species, we have thousands of sporozoites that can be injected into the blood of new patients upon a new blood meal. Session, and for you as medical doctors, I will be talking mostly about the asexual stages that are happening in the erythrocytic cycle, because during the exoerythrocytic cycle the patient will not experience symptoms. Whenever we talk about the erythrocytic cycle and the duration of rupture of RBCs, this is where the patient will show periodicity that helps identifying different species. So as medical doctor, what is important to you is to know more about the properties, about the stages of the asexual erythrocytic cycle, and these will include in my talk characteristics of different stages in different Plasmodia species. I will be mentioning properties of the ring stage, of the schizont stage mostly, and some properties of gametocytes, knowing that the most characteristic gametocytes that can be concluded from a blood smear are those of Plasmodium falciparum because of their crescentric shape. Whereas for the other three, we will not elaborate a lot because these will not conclude about the species that is infecting the patient, and we will need to look for other properties. Now, I would like to remind you about two notions: the difference between a thin and a thick blood film. So basically the thin film is a drop, and this allows us to detect the parasite in case of heavy infections, where just a drop will allow us to see the required stages. For the thick blood film, it happens after concentration of a certain amount of blood, and that happens whenever we have not enough stages within the blood, so we might need to concentrate the blood in order to see those stages. I will start with the ring stage of Vivax, Ovale, and Malariae. I would like to emphasize that for Plasmodium vivax, whenever the red blood cells are infected, they can have a normal to a slightly enlarged size, similar for Ovale. Whereas for Malariae, the size of the red blood cell that is infected can be smaller than normal. It's a little bit smaller than normal. In addition, under optimal conditions in Plasmodium ovale and in Vivax, we can see the Skuffner dots in the preparation. And these Skuffner dots is what you see here in this slide in the infected RBC. For the ring stage of falciparum, it is very important to note that multiple merozoites can infect a single erythrocyte. Thus, within the same red blood cell, we can see 3 or even 4 small rings that might be seen. And more importantly, whenever we see these rings, most of the time we see them at the very edge of the periphery of the cell membrane. This is what we call the position appliquée or position accolée, that is characteristic of ring stages that are close to the edge of the infected RBC. And it's very important to note that because of the multiple infection of the same RBC, lysis of these RBC happen faster, and this is why we do not follow or we do not see under the microscope the other stages, including the trophozoites or the merozoites in the schizont of Plasmodium falciparum. So what we see in terms of diagnosis are either the red blood cells that are infected with multiple rings that are at the edge of the membrane, or also the crescentric gametocytes that I will be showing in the coming slides. Let us now talk about the second stage that happens in an infected RBC, which is the trophozoite stage. I will go again over Vivax, Ovale, and Malariae on the same slide. And in Vivax, I want to dwell to your attention that infected RBCs are enlarged, so they are bigger in size. Same thing happens with the Ovale. However, the enlargement of the RBC is lower than that in case of Vivax. So red blood cells in case of infection with Plasmodium ovale have a slightly enlarged shape, and most of the time it is oval. This is why it is called Plasmodium ovale, and sometimes it gives the aspect of a fimbriated membrane, and that happens also for the ring stages of ovale. So whenever you see an RBC with an fimbriated or star-like plasma membrane, you have to conclude that it is Plasmodium ovale. For malaria, the infection of the RBC is not macrocytic, which means that the infected RBC with Plasmodium malariae does not change the size of the RBC. Now, if we look into more details on trophozoite stages and RBCs that are infected with vivax or ovale, these RBCs might show Skuffner dots under optimal conditions. However, very characteristic of malaria infection is the formation of band form, which is a formation of like a band inside the RBC, and you see it well under staining. Let us now talk about the schizont stage of the four species. Of note, you cannot see schizonts of Plasmodium falciparum in your preparations. The simple reason is that every RBC can be infected by up to 4 ring stages, which makes its lysis faster. So by the rapidity of the lysis of the RBC, most of the time we cannot detect schizonts in the blood smear. This is why I will not talk about schizonts of falciparum. Now, note that the schizont stage can be a conclusion of the infection with either vivax, ovale, or malariae. Why? Because the number of merozoites in these schizonts is indicative of the appropriate infective species. For instance, in case of vivax, we can have the largest size of schizonts with schizonts that can contain 12 up to 24 merozoites. If we talk about ovale, the number of merozoites is half of that in case of vivax. So a mature schizont of Plasmodium ovale contains usually 6 to 12 merozoites with large nuclei. In case of malaria, the schizont is very well characteristic. It has a rosette pattern. It usually contains 6 to 12, but most of the time under a microscope we see it as schizont of 8 merozoites. So to put things simpler to you, if I am to ask you about any of these in a medical case, I will be emphasizing on the largest number of merozoites, which is 24 in vivax, the largest number of merozoites in the schizont of ovale, which is 12, and I will be mentioning 8 merozoites in case of malaria for the sake of clarification. Now remember that again, in case of vivax, the RBCs are quite enlarged, and we can see that. When we talk about ovale infection, the RBC size is slightly enlarged, and most of the time it acquires an oval shape, and sometimes we see a fimbriated plasma membrane, which gives the ragged aspect of an infected RBC. As for Plasmodium malariae, the red blood cell maintain its normal size, and this is why I previously mentioned it is not macrocytic. Again, for schizont stages as well, and upon infection with vivax or ovale, we might see the Skuffner dots. So keep in mind that again, what defines characteristics of falciparum is the presence of multiple rings in the same RBC. In case of trophozoites, malaria is very conclusive if we see band and bar shape of trophozoites in case of malaria. Now, if we move to the schizont stage, here we can conclude a lot about vivax, where a schizont can contain up to 24 merozoites, ovale, where it contains up to 12 merozoites, and malaria, where it is a rosette of usually 8 merozoites.
We reach now the last stage that might be seen in an erythrocytic cycle of any of the 4 Plasmodia species, which is the gametocytes. For gametocytes, as I previously mentioned on the life cycle, that some trophozoites can evolve into either macrogametocytes, which are the female gametocytes, and these present as large in size and have a well-defined nucleus, or the microgametocytes, which are smaller in size with a diffuse nucleus, and these correspond to the male gametocytes. Now, if we look under the microscope on a blood smear of any of these gametocytes, in case of vivax, ovale, and malaria, we cannot have a conclusion because all of them look similar under the microscope. However, in case of Plasmodium falciparum, these gametocytes have a crescent-like shape and can be conclusive. So basically, remember that these gametocytes are taken upon a new blood meal of Anopheles, and macrogametocytes and microgametocytes will fuse to become will become gametes, then fuse to become ookinete, then oocyst, and that happens within the intestine of the Anopheles and then moves to the salivary glands, where the oocyst containing thousands of sporozoites will rupture and liberate new sporozoites upon a new infection. Now, to wrap up this section, I want again to remind you that in case of falciparum, what we see are usually either RBCs infected with multiple rings or concentric gametocytes, and this is what concludes the infection with falciparum. For Vivax to conclude the infection, we should be able to see enlarged red blood cells and, more importantly, schizons with 24 merozoites. When we talk about ovale, the size of the RBC is slightly enlarged. However, what is very characteristic, and we can see it most of the times, is an RBC having a fimbriated or ragged plasma membrane, and if we reach the schizon stage, we can count up to 12 merozoites. Now, when we talk about malaria, and to conclude on this infection, we should be able to see the trophozoites, which might form band and bar, which are very characteristic of malaria, and the other characteristic is usually the schizon stage, which contains 8 merozoites. I will move now to discuss the blood and tissue flagellates, and I will be mentioning two main genus, which are Leishmania and Trypanosoma. Let us start with Leishmania. I remind you that the life cycle of Leishmania species, whether we're talking about Donovani responsible for visceral leishmaniasis, or Tropica responsible for cutaneous leishmaniasis, or Brasiliensis responsible for mucocutaneous leishmaniasis, share all the same life cycle. So that life cycle starts when a scent fly takes a blood meal. It will deposit in our blood flagellated stages that we call promastigotes. These promastigotes are phagocytosed by macrophages, and according to species, these macrophages will develop into appropriate tissue. For instance, in case of Tropica, these macrophages will be ruptured on the skin, causing cutaneous leishmaniasis. When we talk about Donovani, these macrophages will rupture upon multiplication of amastigote stages within viscera, including liver and including spleen, whereas for the mucocutaneous leishmaniasis caused by Brasiliensis, those macrophages will rupture in the mucus area, and this is responsible for the mucocutaneous leishmaniasis. So again, within these macrophages, the promastigotes will lose their flagella. They will transform into amastigotes, non-flagellated forms, which will replicate into these macrophages until lysing them. When a scent fly is taking a new blood meal, what happens is that it is ingesting the infected macrophages with amastigotes. Amastigotes will be liberated within the midgut of the scent fly and will transform back into the promastigote stages. Those promastigote stages will migrate then to the proboscis and will be transmitted into a new patient upon a new blood meal. And on this part, you can see a scent fly, and I will re-emphasize on a fact that usually the females are the ones that transmit the parasitic infections, because these females lay eggs, and these will require a higher amount of blood, which will ensure a better maintenance. Before I emphasize on the different stages of the life cycle of Leishmania, I would like to dwell to your attention that both Leishmania and Trypanosoma belong to the Kinetoplastida. What do we mean by Kinetoplastida? These Kinetoplastida are stages that have a kinetoplast. What are kinetoplasts? Kinetoplasts are usually dense DNA containing granules that are located within the single mitochondrion that always associates with the basis of the flagellum. So basically, these kinetoplasts are very conserved among species and are usually used in the PCR test. Going back to Leishmania species, and for the three of them, they have two stages in their life cycles, the promastigote and the amastigote stage. Let us start first with the properties of the promastigote, which is the flagellated stage of the parasite. So this is an elongated stage. You can see two dense areas, one that is bigger, which corresponds to the nucleus of the promastigote, and another one that is smaller, which corresponds to the kinetoplast, and which is located at the anterior side of the parasite, knowing that the anterior side of the stage is the side where you see the flagellum. So basically, within that promastigote, the flagellum is located anterior. The kinetoplast is at the basis of this flagellum, so it occupies also an anterior position for the nucleus. And then comes the nucleus, which also stains dark. This is another image of promastigote stage. This time it is a promastigote from Leishmania donovani, which is responsible for visceral leishmaniasis. You can see here the flagellum, which is located at the anterior side of the parasite, and this is the posterior end that is at the opposite side of the stage. And remember that these promastigotes are the flagellated forms because amastigotes. And this is an immunofluorescence microscopy showing also promastigote stages. So you can see here in green the promastigote with the flagellum located at the anterior side, the kinetoplast, which is the blue small dot that is also anterior if we if we compare it to the nucleus, and we have then the nucleus, which is a larger dot, which is stained by blue according to different antibodies. So basically here again, this is the promastigote with the flagellum at the anterior part, kinetoplast at. Now that we discussed the promastigote stages that we do not usually see in patients in clinical specimen because these are the stages that are transmitted by the scent fly, I will be talking about the amastigote stage, which presents basically in patients. So remember that the symptoms present whenever macrophages that contain replicating amastigotes rupture in the corresponding tissue, causing the disease. So these amastigote stages are basically the clinical specimen, the clinical diagnostic specimen of the infection by different Leishmania species. It's worth noting that these stages are small. They lost their flagella, so they are not flagellated, and you can clearly see as well that they have a kinetoplast which occupies an anterior position if we compare it to the nucleus. And if we look at cells infected with amastigotes from trypanosoma or from Leishmania, specifically Trypanosoma cruzi, because only American trypanosomiasis present this amastigote stage. If we look again to the clinical specimen isolated from a patient infected with Leishmania or Trypanosoma cruzi, we are not capable of distinguishing the amastigotes of these two parasites. We can do that by performing a PCR test because kinetoplasts are very conserved among either Leishmania. To put side by side the two stages of Leishmania, here you can see on the left the promastigote stages with the flagella, kinetoplast, anterior position, nucleus, and on the left you can see the amastigote stages, which are non-flagellated stages, which are smaller in size and which also present the nucleus and the kinetoplast, which is anterior to the nucleus. The second part of blood and tissue flagellates I will be talking about is trypanosoma. I want to remind you, and I'm sure Dr. Awar mentioned to you, that we can see either African trypanosomas, which regroup Trypanosoma brucei gambiense and Trypanosoma brucei rhodesiense, which both are transmitted by tsetse fly that you can see here, and the Chagas disease, which is caused by Trypanosoma cruzi, and this is the American trypanosomiasis, and this is transmitted by the triatomine bug that you can see here. Both African and American trypanosoma species move by using their flagella, and they both belong to the order of Kinetoplastida.
I will start discussing the life cycle of African trypanosomas, which regroup Trypanosoma brucei gambiense and Trypanosoma brucei rhodesiense. The cycle or the infection begins when the tsetse fly takes a blood meal and it will inject into our blood metacyclic trypomastigote stages. These trypomastigote stages will divide by binary fission in various body fluids, including blood, lymph, and spinal fluid. And whenever the tsetse fly is taking a new blood meal, it will ingest those trypomastigote stages, which will transform into procyclic trypomastigotes in the midgut of the tsetse fly. These promastigotes will further divide and will transform into epimastigotes in the midgut, then will move to the salivary glands, where the epimastigotes will transform into metacyclic trypomastigotes, which are the. Let me now go over the life cycle of Trypanosoma cruzi, which is responsible for the American trypanosomiasis or Chagas disease. So the infection with Trypanosoma cruzi starts whenever a kissing bug or a triatomine bug is taking a blood meal. This is called kissing bug because it usually takes its blood meal in areas that surround the mouth or the eye, so wherever we have soft tissue and more accessible capillaries of blood. Whenever it takes the blood meal, it will defecate within the wound that it created, and it will liberate metacyclic trypomastigotes. These metacyclic trypomastigotes will penetrate into various tissues, in which they will transform into amastigote stages. And note that the amastigote stages are present either in the case of Trypanosoma cruzi or in the case of Leishmania species. It is not a stage that we find in case of African Trypanosoma manifested as either brucei gambiense or rhodesiense. So these amastigote stages will divide by binary fission in cells of infected tissue, and we will reach some of them that will transform back into trypomastigotes whenever amastigotes rupture the cell they infected. So these trypomastigotes will be taken again by a triatomine bug upon a new blood meal. They will transform into epimastigotes within the midgut of this triatomine bug. They will divide by binary fission, and then they will transform into metacyclic trypomastigotes in the hindgut, which is the posterior part of the intestine of the triatomine bug, and these metacyclic trypomastigotes will be liberated upon defecation of a triatomine bug in the wound it created whenever it takes a new blood meal. So as a summary, for Trypanosoma brucei gambiense, we mostly find the trypomastigote stages and the epimastigote stages in the life cycle, whereas for this brings me to define to you the differences between the four stages that we discussed on the life cycles of Leishmania or Trypanosoma, which are the amastigote stage, the promastigote stage, the epimastigote stage, and the trypomastigote stage. Remember that when we talked about Leishmania, we mentioned amastigotes and promastigotes, both of which have a kinetoplast that is located at the anterior part of the stage, and these thus occupy an anterior position compared to the nucleus. While amastigotes lack a flagellum, promastigotes have a flagellum that protrudes from one side of the stage. If we look at the epimastigote stage that we found in both cases of Trypanosoma, whether African or American, and that happened within the vector, whether the tsetse fly in case of Trypanosoma brucei or triatomine bug in case of Trypanosoma cruzi. So what differs in this stage from promastigotes or trypomastigotes is that the flagellum is usually located at half of the size of the body, so it occupies half the length of the stage. Again, the kinetoplast is also located at the anterior side of the stage, and it is anterior if we compare it to the nucleus. For trypomastigote stages, the difference with promastigotes and epimastigotes is that the flagellum is all over the surface of the stage, and this flagellum is
always close to the kinetoplast as all of the other stages. However, the difference between trypomastigotes and the others is that this kinetoplast occupies a posterior position if we compare it to the nucleus. So, as a summary, amastigotes lack flagella. Promastigotes have a protruding flagellum from one side of the stage. Epimastigotes have a covering flagellum of half the length of the stage, and trypomastigotes have a flagellum that covers the full length of the stage, and this is what we call an endoflagellum. Now, if we go back to the position of kinetoplast as compared to the nucleus, the kinetoplast in amastigotes, promastigotes, and epimastigotes is anterior, while in trypomastigote stages, this kinetoplast is posterior as compared to. Let me start showing you some pictures of trypomastigotes of African trypanosoma, which are Trypanosoma brucei, whether gambiense or rhodesiense. So as you can see, these trypomastigotes have this undulating membrane that has the flagellum covering the full surface of the stage. You cannot distinguish between trypomastigotes of brucei gambiense or those of brucei rhodesiense. Note that these are trypomastigotes. This means that the kinetoplast is always at the posterior side as compared to the nucleus. And it is this flagellum, the flagellum is running along the undulating membrane that is all over the surface of the parasite. And this is the diagnostic stage we find in patients. It can be seen in either blood smears or also in the. If I move on now to show you some characteristics of Trypanosoma cruzi trypomastigotes. As for Trypanosoma brucei trypomastigotes, the kinetoplast occupies a posterior position if compared to the nucleus. And what is very important is that trypomastigotes of Trypanosoma cruzi may manifest as a C shape. When we talk about the C shape, it is the parasite in the chronic form of the disease, C like chronic. And if we see them as an S shape, it means that the disease is in its acute phase. So again, when we talk about Trypanosoma cruzi trypomastigotes, these are. And I will finish my session on these two pictures. On your left you see the trypomastigotes of Trypanosoma cruzi, and again this is an S shape, which means that this patient is presenting the acute phase of Chagas disease. And also I want to re-emphasize on the fact that in Trypanosoma cruzi we see an additional stage, which is the amastigote non-flagellated stage. And again, if you see a biopsy of an infected tissue from Trypanosoma cruzi or Leishmania donovani, you are not capable of distinguishing the amastigote stages between these two parasites, and it will take you either going back to the history of patient and the symptoms, or doing PCR with appropriate primers in.
So to wrap up, and in accordance with the learning outcomes that were presented at the beginning of this session, at the end of this lecture, students are able now to recognize the characteristics of trophozoites and cysts of intestinal moving parasites, such as, for example, entamoeba, such as Giardia, such as Trichomonas. They are able to identify the oocysts of different sporozoans, and we focused on Cryptosporidium. They are able to recognize amastigote stages and trypomastigote stages, as well as other stages that exist in case of Leishmania and Trypanosoma. For the second learning outcome, we have covered microscopic examination of stool samples from patients infected with intestinal sporozoans. We covered blood smears in case of Plasmodium as well as in case of Filarida. We covered certain biopsies also. We repeated very briefly the life cycle of the selected intestinal and blood and tissue protozoa, the respective stages in different organs, in order to have an idea about the pathogenesis that is caused by these parasitic infections. As for the fourth learning outcome, we restated very briefly for each protozoan parasite the disease, its symptom, to reinforce the material that was covered in the different parasitology sessions by Dr. Awar or myself. And finally, we gave an overview on cycle symptoms of select intestinal blood and tissue protozoa, identification of their stages and clinical specimen. This is, of course, going to help students to make the convenient medical decision for treatment at later stages.
With that said, I close the session and I thank you for your attention. Please do not hesitate to contact me if you have any questions related to the material. Thank you.